Dear urologists on Preeti Pure Urology Forum, good evening, one and all. Today, our topic is enucleation versus bipolar enucleation versus laser enucleation. To be honest, most of the people either do this or that. Very few people will do both and excel in both. Today, our speaker is Dr. Mohammad Taif Bendigeri, who has practiced bipolar enucleation for large glands and attained certain experience. After that, he also is experienced in home laser enucleation of the prostate for a significant period of around 7 to 10 years. So, taking his experience into consideration, we requested him to present on comparison of both techniques. Some people say that bipolar enucleation is more mechanical, but when you look at the surgery, it looks so beautiful and simple, and everybody can see a vascular plane sweeping with the bipolar, whatever loop or anything. But few people in home laser can do almost same, but it takes time and it appears taxing to do also. Whereas bipolar enucleation, somebody who is good can finish in a very short time. So let's listen from him both comparison. In fact, I will introduce first the Taif. Where is it? Sorry, I shared wrong, I think. Can I go back? Stop sharing. Share screen. Where is the PPT? Just 1 second.
Back one second.
You open the PPT. This is the one. Yeah. So I will share the screen. Sorry for the inconvenience.
Back this end.
Open. Oh, I have to close the
Full screen.
no, it's not shared. Is the screen visible now? Did I share Taif? Taif?
Show them this.
Hello? Share screen. Yeah. So today topic is laser enucleation versus bipolar enucleation. Dr. Mohammad Taif Bendigeri. He has done his MBBS, his MS General Surgery, MCH Gold Medal from Rajiv Gandhi University of Health Sciences. Presently working as consultant urologist at Asian Institute of Nephrology and Urology, Hyderabad. Operating faculty in multiple live operative workshops in endourology and laparoscopic urology. Expert in transplant also and andrology. Published around 15 publications in national and international journals. Multiple presentations in national and international conferences. Authorized 3 chapters in urology books. Member of Society of General Urinary Surgeons, Telangana State and AP. Member of Urological Society of India. Member of Endourology Society. With this introduction, I will hand over the program to Dr. Taif. Taif, thank you once again for accepting the invitation. Am I audible, Taif? You have to unmute. Taif, unmute.
Sorry, I'm not sure.
Did you make unmute Taif?
Sorry.
Did you make him co-host?
Yes, sir.
Where is it?
This participant, sir.
Is he co-host? Yes.
Sorry, I'm not sure.
Taif, unmute. Below it is on the left column. It is there. Extreme left. Screen. He exited. He will come back.
Sadesh Babu. Babu, sir.
He is online and he will be taking time. So meanwhile, you can ask questions. As far as my experience, I have not done bipolar enucleation many. I tried, I have the equipment, but I felt after the middle part of the gland, you feel you have to use a lot of force to enucleate. Whereas in laser, whether it is TFL or ohmium laser, if you find the plane, you can go in the plane and do it. That is my concern. In bipolar enucleation, I have seen slightly more incidents of incontinence. So Taif has joined. Unmute Taif. Video and audio unmute Taif. Yeah, call him. Call him and unmute. Left side unmute. Hmm? Hello.
Yes, sir. So please once check.
Yeah.
Hello, sir. Can you hear me?
Yeah, I can hear you.
There is some issue with the
Audio?
audio of my laptop, sir. So I'm just
No problem. Now I can hear you through the other source.
Yeah.
Not an issue. You can speak well, but if you can share the screen, it is sufficient.
Yes, sir.
Share the screen and talk through the phone.
Yes, sir. That's what I'm planning.
Fair enough. Yeah, good, good. Voice is clear. Yeah. Now I'm able to see the screen. I'm in the pure urology talk.
Oh, sorry, sir.
Can you see the slide, sir?
Yeah. It is a little slow in uploading, but it's okay.
I'll just go slow with the slide movement.
Yeah.
Good evening, everyone. Sorry for the technical issues. Like sir described, today's topic would be laser enucleation versus bipolar enucleation. Of late, for the last around 10 to 15 years, the discussion on enucleation has really become more and more interesting with a lot more modalities of energy coming up. For almost close to 3 decades, it was predominantly HOLEP, which was the go-to thing in case of enucleation. But over a period of years, slowly the focus has shifted, wherein the consideration for alternatives for HOLEP has come, alternative lasers were seen, and alternative energy sources have come up. Eventually, now we are discussing as to how do they compare head-on and how do we proceed later.
Yes.
I think my slides are not okay.
First click. Yeah.
Okay. So first thing, as we look into this topic of laser enucleation versus bipolar enucleation, we come across another entity called as an endoscopic enucleation
Hello.
procedures translaterally are all included in this. Now, why do we need to discuss this point? So we again look at these points. One is the evolution. How did this all evolve? say, if you see the logical thing that one might feel that is laser enucleation or HOLEP for that matter was the first thing to start up. And am I audible, sir? Is it stuck anywhere?
Yes, yes, I'm audible.
Okay, fine, sir.
You are audible.
When you look at the evolution of endoscopic enucleation, wherein HOLEP started in 98, 99 kind of thing by Peter Gilling, and it just took off from there. If we look into the evolution of bipolar enucleation, actually bipolar enucleation or current-based enucleation, non-laser enucleation, started way back. It was the first documented thing was in 1983 with monopolar energy and a dissector probe. So things with bipolar or monopolar enucleation actually started almost 15 years prior to laser enucleation. But the evolution took totally different routes, and somehow where laser enucleation became extremely popular, the non-laser enucleations did not pick up in the same way. If you look at the efficiency as we go through later, and we, as all of us have come across in multiple forums and multiple conferences and workshops, the documentation in the literature on efficiency is almost similar. Now, when both started evolving, rather one started evolving earlier and efficiency was the same, then what is it that differentiates the two? Eventually, it is the practicality. So there has to be something wherein laser enucleation still continues to be the favor of the trend, and wherein bipolar or monopolar enucleation is yet to catch up, though being on par with it. So when we see what are the options for laser enucleation, we have where we started with the KDP and diode lasers, and the most forerunner of lasers has been holmium YAG. There was thulium YAG, which came in and gave a very good sort of an alternative for holmium lasers as an alternative energy source for enucleation. But slowly now, for last 5 years and of late, the most crucial discussion is between holmium YAG and thulium fiber laser, that is THUCLAB. So this is with regards to the options with regards to laser enucleation. Eventually, from the way things are going, probably the discussion would limit to modifications of holmium and modifications of thulium fiber, and most predominantly thulium fiber going forward. If you look at what were the options one has for bipolar enucleation, the other side of the story. So, like I said, it started with something called as dissector probes in monopolar energy way back in 1983, 4 decades ago. And then somewhere around 88, 89, there was a very popular enucleation technique in monopolar, wherein it was directly done with the beak. So this is how it actually started evolving. But as the interest progressed, there has been a lot of improvisation with regards to the probes with which bipolar enucleation can be done. What are these? One of the thing which is there in Olympus is the spatula with the lobe. As you can see in the top right, there is a solid, rigid this thing spatula which helps to mechanically lift and enucleate with a cutting or current electrode beneath that. Along with that, we have got multiple options across various companies which use different shapes of what you call a wedge-shaped loop. So there is basically a wedge which can help in creating and lifting the adenoma and creating a plane. So we have something called a button or a mushroom-shaped thing in Olympus, a cylindrical sort of a wedge in Olympus, and a triangular wedge-shaped thing in stores. So the basic concept remains the same. Slight variations and a wedge-shaped thing which can lift off the adenoma, and at the same time these wedges can be used to even vaporize it. So if at all there are any rigid areas or any small nodules which are getting left behind. So if we see, coming back to the laser, the types of lasers that are being used and the manner in which we have been using has evolved dramatically. Starting off with ND-YAG and holmium YAG to presently thulium YAG laser and thulium fiber laser. So what are the characters which decided these evolution is predominantly the parameters of the lasers. And most importantly, what is the wavelength of absorption? How much of it is absorbed in the water versus in the hemoglobin? And this coefficient of absorption in water eventually gives us what is it? The hemostatic effect. So if we have to look at the different lasers that are used and what decides which laser we buy, so we look into usually the subjective elements, not just the theoretical things. Theoretically, obviously, we have come across that most of the things match up on deliverables of efficiency. But yes, what impacts is the ease of usage. How comfortable are you as a person using that energy source, and what are the impacts on the tissue? Again, impact on the tissue basically is in terms of the hemostatic impact and the tissue dissection impact. We have all seen in various workshops how holmium laser versus a thulium YAG laser or thulium fiber laser varies, and the kind of dissection that happens with holmium versus a thulium, and the reasons for that being the plasma bubbles that are created versus the hemostatic advantage of thulium fiber and thulium YAG over holmium YAG. So these are the pros and cons of selecting between two different lasers, along with the non-theoretical concerns of logistic issues and the financial constraints. The most crucial thing that for enucleation with regards to a laser comes is how is the hemostatic effect and how is the plasma bubble creation and the shock wave dissection. Hemostatic effect, no doubt, is a lot better with thulium fiber and thulium YAG, whereas the plasma bubble creation and shock wave dissection is much better in holmium. So eventually one has to decide what one wants to opt for. And how do these vary? With regards to the laser usage that we are doing, the frequency and energy can be modulated, as well as the pulse modulation can be done, which gives a variation of the energy which is delivered and the desired impact on the tissues. And the size of the fiber can also be modified, which will determine the density of the energy which is delivered. Now, when we see so many different energies which are there, most of the times when new energy comes up, it has to be compared with the previous gold standard. So for all endoscopic enucleations, the benchmark had been always the open prostatectomy. So there has been multiple studies and meta-analysis where holmium laser, HOLEP compared with open prostatectomy was done. Then holmium was compared with thulium YAG. Holmium is now being considered with thulium fiber. And it's comparative for today's discussion, holmium versus a bipolar. Now, even bipolar compared with open prostatectomy has been done. So various permutations and combinations of studies have happened. And what we have seen is with regards to various factors as to feasibility. So whether a particular energy source for endoscopic enucleation has been feasible, yes, all these energy sources have been feasible sources of alternatives for open prostatectomy. How has been the efficiency? Again, multiple studies across different parameters, efficiency is proven beyond doubt. Safety across different parameters, different comorbid conditions and age groups has been established. The durability of long-term studies are also the same. Complications, well, yes, there is a lot of variation, and since the overlap itself is too high, but yes, overall the complications are also matched. One of the most important thing which HOLEP sort of revolutionized as compared to TURP was its use in antiplatelet settings and anticoagulant settings. But yes, it was not something which was very new or revolutionary to holmium laser, which was wrongly attributed at the turn of the millennium. That holmium laser is one that is giving us the advantage to operate in antiplatelet and anticoagulant. It was actually the principle of enucleation. And over the next 2 decades, now we have seen, irrespective of the energy source that you use, even with bipolar energy, you can do the same thing in the antiplatelet, anticoagulant settings. So what we now know is results across multiple studies are similar and all these are comparable. But if that is the scenario, why are we still seeing almost 90 or 95% of the times when there is a discussion or when there is a consideration for enucleation, it is laser enucleation and not a more, what I can say, cost-effective bipolar enucleation. So theoretically, it is still comparable, but results are also same. But still, like a very famous line from our Telugu film industry by the legendary character of Akhanda is, whatever you say, eventually both are not the same. For someone who is not well versed with Telugu film industry, it is something like that character, something like the Terminator and all. So irrespective of whatever you say, both are not the same. Then what is it that is differentiating laser enucleation versus bipolar enucleation? I'm sure when we open up discussion, Chandramohan sir will be firing me on most of these parameters. I tried to think what could he be asking me on. So if at all, theoretically, if it is the same, why it is differing between the two? So let us see during the course of the procedure, what are the steps that we encounter. And definitely when theoretically it is same, there has to be a practical difference between the two. There is a subjective difference between the two energy source or different energy sources. Let's see the first thing. When you are doing an initial marking with regards to a laser energy or with regards to a bipolar energy. So if you are doing a classic 3-lobe thing, you are supposed to make a groove in the floor and you are supposed to make a groove at the roof. So in bipolar, when you are using, you can do this marking and grooving just with simple resections. Whereas in laser, you would take more time so that the grooves are created. Wherein if you are using a vaporization, the wedge-shaped loops, you can directly vaporize that channel at 6 o'clock and 12 o'clock. So this differentiation, so you might be making a very quick apical mucosal marking with laser, wherein you might take more time with regards to the wedge loops in that. If you see with regards to the dissection of the plane, now dissection of plane has got nothing to do with the energy source which is being used. It is a parameter, it is a property of the adenoma that we are handling. If you are taking a 80cc, 100cc gland, the plane is already been created nicely and the surgical plane is there. And it is something sort of the zone between 4 o'clock and 8 o'clock, it is like a wow zone of enucleation. Irrespective of whatever you do, until you are in that wow zone of 4 o'clock and 8 o'clock, the procedure will look simply fantastic. But this is not the plane or this is not the phase where you judge the procedure. The moment you create higher up, more laterally, say more anteriorly, beyond 4 o'clock and above and 8 o'clock and above, that is where the adhesions become more prominent. And that is where the dissection and the use of energy is very important. Now, if you're using a bipolar loop, you will have to make sure that there has to be a judicious use of mechanical elevation and the usage of either the loop or the wedge-shaped probe to vaporize and create the dissection. Whereas in laser, your laser will do that same amount of dissection without or very minimal mechanical energy. With regards to hemostasis, bipolar hemostasis is as good or maybe sometimes even better and easier than compared to a laser hemostasis. As we come across many times where a bleeder is hitting head on towards the scope, we might have difficulty in hemostasing the vessel directly, especially in holmium laser, wherein there might be some amount of undermining of the tissue happening because of the same plasma bubbles that we are so happy with dissecting the plane. This is the advantage in thulium YAG or thulium fiber. But in bipolar, this advantage is something akin to the thulium fiber. So your bipolar gets the advantage and it replicates almost similar to your thulium fiber or thulium lag in case of hemostasis. Yeah. If we want to see what are the ability to perform various improvisations. Now, again, for last 5 to 8 years, lot of discussion has come up that en-bloc enucleation is the solution for all the problems of incontinence in enucleation of the prostate. Can we do en-bloc with bipolar? Yes, because again, it is a surgical technique and it has got nothing to do with the energy source. But unfortunately, just en-bloc is not the solution for getting a zero incontinence. It is a multifactorial issue. And yes, if you are keen to do an en-bloc, an early apical release, or any of these improvisations, all these improvisations can be as well done with bipolar also. But yes, you cannot do it the same way as you handle a laser fiber because the probe would be slightly wider. You will have to improvise your technique. You will have to make sure that you are creating the space for the particular thicker probe also to accommodate. So yes, it will be slightly more trickier to do that. Now, the what you can say, the crux of bipolar enucleation lagging behind is the aspect of mechanical force and its impact on incontinence? And are there any ways to reduce this mechanical force? So mechanical force, till the time it is coaxial and it is not having a relative mechanical force at the sphincter, which might form a fulcrum kind of thing. So if you're not having a shearing effect and you are not damaging the sphincter, the mechanical force tends to be safe. But still, there has to be ways in which the mechanical force has to be reduced. What are the ways? The usage of these wedge-shaped probes which have come makes you use that in a loop kind of a thing, wherein you need not push the entire adenoma with your sheath assembly, and you can just very gently lift it with the use of the shape of the wedge, which can create a plane. So that is use of a wedge-shaped probe. And second is, there are adhesions between the adenoma and the capsule. And instead of relying more or rather predominantly on the mechanical force for these adherent zones to separate off, we have to use the energy source also judiciously and liberally, so that these adhesions are released with energy and not mechanical force. So these two aspects, when inculcated, can reduce the usage of mechanical force in a significant manner. But yes, bipolar energy cannot negate or get down to bare minimum the amount of mechanical force which is being used when you compare it with the laser enucleations. Outcomes. So the outcomes, like we have seen, again, theoretically, it matches. If you see the practicality, how satisfied you would be with regards to the fossa at the end of a bipolar enucleation versus enuclear or laser enucleation, it is exactly the same. Rather, one advantage is if there are small nodules which are left behind in HOLEP, we have a tough time getting rid of it, which is advantageous in bipolar, that you can instantly vaporize, just like what you can do in thuliumia. So the moment there is a small nodule which is cropping up, you can vaporize it. This addition of vaporization is an advantage over a HOLEP. So again, the classic encounter that we get across, the most important thing is incidence of incontinence. The higher the amount of mechanical force that we use, the higher is the chance that is a shearing damage that can happen at the sphincter. One has to be extremely careful with regards to the angulation of lifting if you have to preserve it. But yes, if you can reduce your mechanical force usage, the incontinence is definitely going to be a lot less. If not, it is a common occurrence, especially earlier in the learning curve, that when we tend to use a predominant mechanical force, thinking that bipolar enucleation is mainly about mechanically pushing the adenoma, the incontinence rates tend to be high. And that is the reason why, rather one of the strongest reason why most of the people drop out of incorporating bipolar enucleation in their practice during their learning curve. So learning curve, unfortunately, is not structured enough with regards to endoscopic enucleation in most of the areas. If you are using laser enucleation and your learning curve is there, subconsciously you are primed that you will not be using a lot of mechanical energy, and the learning curve tends to be a lot more smoother in the way that whenever you are not covering it up with enucleation, you can convert it off to TURP. The problem with bipolar learning curve is, the moment it is not happening, you tend to feel that it is a minor improvisation of the TURP, and they are better off doing TURP as compared to struggling with the learning curve of bipolar enucleation. So the novelty factor that learning curve of a laser gives might not be as exciting for the learning curve of a bipolar enucleation, along with the fear of early learning curve incontinence. So definitely learning curve is more harsh in case of a bipolar enucleation as compared to a laser one. So eventually one of the common questions that we come across is, if you are comparing head on, which one to opt? It is just like answering which car to buy. So the answer would be different for a beginner who is just about going ahead, venturing into learning enucleation, vis-a-vis a person who has used and been regularly using enucleation. For him or her, the decision would be totally different. Versus if you are working in an institute or a department wherein the resources are extremely high, there the decision would be totally different. So individual situation would merit individual assessment and making a decision on that. So when we come across all these things, there are two common things which keeps coming up. Which is the best laser? Which is the best laser to buy? Or which is the best laser out of all these things? And very beautifully summed up by Dr. Scoffon. Which is the best laser is a understatement or an incomplete question. Rather, in his words, I would quote that the proper question should be, which is the best laser for EEP in the hands of an individual surgeon using different enucleation techniques for an individual patient in a specific department and hospital and in a specific country. So these are the various variables which decide which is the best laser that you can use. And now when you are so much confused as to which is the best laser to opt, the other question is laser mandatory? And like we said, like we have just seen, theoretically and the result wise, it is all the same. Laser is not mandatory, but do we really need them? I think as of now, even now, we would say that yes, we still need them just because of if I go and put a video, I would say that it is the man behind the machine, which is more important than the machine itself. So if you see for people and urologists in India, if you see Dr. Anil Vashni or Dr. Pankaj Maheshwari, who are experts in HOLEP, you are in awe of HOLEP being such a wonderful procedure. You see a person, say, Dr. Mallikarjun doing a bipolar enucleation and his finesse, you are awed with that bipolar enucleation. The same thing, it is irrespective of that. If you see Dr. Chandramohan sir during RRS, it is like RRS is the solution for everything. But if you same time see Dr. S.K. Pal sir do PCNL, you feel that yes, PCNL is the solution for that. It is not just the procedure or the machine, it is the man and the expertise behind them, which is key. And the mechanism and principle of surgery has to be given more importance than the type of laser and the type of energy. The energy source is actually secondary to surgical principles, and that is how we have to consider any particular entity. And eventually, it is the optimal utilization which is best suited to the individual situation need that will decide that the results are perfectly delivered. So I'm not sure whether if I run these two videos of a HOLEP N block.
Yeah, run. We will see, because it's a surgical technique based one.
Sir.
You can play through your computer.
I think so, sir.
Instead of in PPT, you can close this, go to your desktop and play also. It's okay, because audience like to like this. You play. Yeah, you can play like this. Yes, it is playing. Okay.
So this would be a standard N block HOLEP. So my initial intent was to run both bipolar enucleation and HOLEP on the same screen side by side for the audience to see how different steps would be there. But I think most of us would have already seen most of the videos and the techniques of these procedures. So I don't think I might add in anything novel to this. I'll just keep it slightly faster so that if it case it holds up.
What is the laser company you are using here?
So this is a Quanta, sir. Quanta 100 watt.
And what laser settings for the incision?
Laser settings is the maximum energy that it gives, that is 1.8 into 45. I think there is a lag. I'll keep it at a regular speed only. So I usually tend to use at 1.8 and 45. For some technical reasons, the maximum that a 100 watt Quanta can deliver is around 80 watts only. So
Okay.
if you want to go actually 100 watt and above, I think you have to go for a much higher capacity of Quanta or the other source of luminance. So the standard incision all around, sir, making sure that circumferentially we make the incision. And this is the crux of en bloc HOLEP, wherein early apical release is the key for it.
What is the laser fiber size? 550 or 400?
550, sir.
Okay.
Because
During giving this incision in the beginning, usually this is the place submucosal vessels little disturbs the vision, but not for a long time. Do you think this incision should be hemostatic or cutting more?
That is yes, sir. So that is one thing. Either you reduce your incision power settings and use it, or use a coagulative setting, the low power coagulation settings which are there, and do the mucosal incision. The mucosal small vessels which are there get coagulated, and your view is not hampered. So definitely that gives a lot of advantage if you are using to give the mucosal cut. So
and most of the times, homium laser, even if you don't touch, if you keep a millimeter distance, it will nicely lift. Is it
yes,
true that it is non-contact mode? Lot of the surgeons use, even though it is
yes,
a contact laser.
The advantage here is you are, rather than relying on the contact of the laser with the tissue, you are using the shockwave and the plasma bubble which is getting created. So that is actually what makes a difference. Then those bubbles sort of create a disruption in the tissues, and there is a separation of the tissues happening, and this aids in the creation of the plane. But at the same time, it is a tough taskmaster, because the minute you are not in the plane, or in case, say, classically when you are anteriorly, wherein fibromuscular stroma is there, there is no such plane as such. You have to cut across the fibromuscular stroma. That is where it doesn't look that smooth, and it feels that you are cutting through a tissue. And whenever you are cutting through the tissue, holmium laser doesn't look that attractive. It is only when you are in the proper plane, that is where it looks very beautiful and appealing. And the
If
minute
by
you are
chance the beginner goes in a wrong place, tips normal thulium fiber laser, you can cut and go, and you can leave. Everything looks hemostatic, so you can proceed. People say in homium laser enucleation, if you go off the plane, sometimes it is difficult to get back and give a normal look. It will take time, experience.
Yes, sir. Yes, sir. Very true, sir. That is what I'm telling. Holmium laser enucleation, the learning curve is very
Learning
rigid.
curve is steep.
Yeah, steep. And it is sort of like studying in a very strict school, sir. So you might feel that the teacher is very harsh and very strict, but eventually, if you come out of it, you are a much happier and a much
good student,
groomed person. So in the same way, the learning curve is steep. The excuse for missing out the plane is very, what you can say, it will not make much of a difference practically, but it will look very depressing kind of a thing intraoperatively. It might be just a few nodules which you have left behind, but it will look so bad when you're doing a HOLEP that you feel disappointed that I have not been up to the mark kind of thing. So it should be rather taken as
that's why many people stop using the machine and keep it aside. I mean, initially, in the hospital, they keep it aside when they don't learn properly.
Yes, sir. I would say that for someone who is having a laser thing, you have to start. Even if it is not looking good enough, even if it is not looking appealing, you miss the plane, you keep progressing. TURP can be done anytime. Even if we feel that a lot of tissue has been left behind and you have gone into adenoma, all it needs is just few chips with the TUR at the end of it. But once you start completing the adenoma, enucleating and putting it across, over a period of, say, the studies for the learning curve quotes the learning curve for HOLEP somewhere at around 20 or 30 cases. So for lesser skilled surgeon like me, I took around 30, 40 or maybe even 50 cases till the time I felt that yes, I do a fairly good kind of a job. So it is an individual thing. Someone might pick very early, someone might pick slow, but yes, everyone who has been persistent enough has learned the HOLEP till now. So it is just a matter of
what is the ideal size initially when somebody buy mission and start on his own by seeing the videos? what is the ideal size you recommend? 70, 60, something like that?
Yes, sir. Yes, that is the sweet zone, sir. That is, say, what your upper limit of TURP. So, like 70 or 80 would be your upper limit of doing a TUR. So, that is the area where enucleation becomes easier because the surgical plane would have been developed in such kind of a glands rather than being scared and trying to do HOLEP in 30 or 40 cc glands. You
Yeah.
can do, experts have been doing, but for a beginner, small glands or 30 or 40 cc or 60 cc, the planes are not very well developed, and it is more depressing to try to do enucleation and learn enucleation for smaller glands. So I would say minimum is around 70, 80, wherein it is fairly good enough. You try doing the enucleation, and the moment you feel you are not progressing, you still are confident enough of doing your TURP anytime. So that is the gland where we need to start. And if at all you are being over heroic and doing directly 100 plus glands, you might have tough time completing the case. So not very large glands, but yes, the upper limit of what your TURP gland would normally be. So this would be a classic en bloc HOLEP, and if at all we were to see what bipolar enucleation classically we do, and this is one of the videos of transrectal bipolar enucleation that we had along with animation, and this is the steps that we do. The basic principles are the same: mucosal incision, complete enucleation, and whether you want to do a morcellation or in situ resection. The first steps are typically the same: mucosal incision on either side, all along. So this is actually the similar thing with the en bloc HOLEP. So en bloc laser enucleation, I would say. So the same thing that you can do with your regular TURP loops as well. So now
Taif,
you
what
can
is
see,
the depth of penetration comparison between two? Laser is less depth penetration when compared to bipolar at the given point.
sir,
What do you think?
the energy transfer is comparable, sir. Bipolar is 0.2 mm, something similar to thulium fiber. Actually, holmium laser is around 0.4 mm. So this is the transmission of energy. The coagulation zone is said to be somewhere around 2 to 4 mm for holmium and 5 mm for bipolar. So maybe at the apical zone, less energy usage with bipolar is advisable. So this is one of the tungsten loops that we can use. And with this loop, one of the disadvantages is you will need a specialized 12-degree telescope to make sure that the upper tongue loop is visualized, spatula is visualized. Now, if you see in this surgical plane, the minute you move across that, the spatula tends to lift the adenoma and the plane is created. And the principle of enucleation is the same thing. You create and lift the surgical plane and coagulate these vessels at the intersection. And this is the reason why bipolar enucleation also gives the same advantage and efficiency even in patients with anticoagulation or antiplatelet settings. So we would enter the bladder neck at around 12 o'clock or 1 o'clock and then sweep across down at the bladder neck. This, if you can correlate, these were the exact steps that we were doing in an en bloc HOLEP a few minutes back that we noticed. You enter the bladder neck at around 12 o'clock or 1 o'clock and keep moving down with laser. What I was doing with holmium laser in the previous video, the same thing we can do with the spatula in the bipolar thing. Relatively, your usage and tendency to use a mechanical force would be higher. That is what you have to be consciously aware and make sure that if there are any dense adhesions, especially at say 9 o'clock and 3 o'clock, you have to be more liberal with using your cutting energy rather than using more of force. And once you do at the one lobe, the same thing is replicated on the other lobe, and basically the principle remains the same. So create a plane. The plane is there for us to reach out irrespective of what is the energy source. And yes, and one sweeping motion with this modified spatula creates the plane all across. and that is where we'll have to keep proceeding anteriorly. That is the smallest segment, right? Anteriorly, the prostate is the shortest, and that is the area where the axis is relatively straighter and there is no curvature of the prostate adenoma. So that is the reason for every en bloc enucleation, we try to enter the bladder neck at around between 11 and 1 rather than anything else. So the same thing is being replicated here with the bipolar energy. We are lifting the adenoma and coagulating at the same time. And once you enter the bladder neck on the left lobe, again you sweep down across the lobe from the bladder neck coming distally and coagulating the bleeders. So one of the ways which has been suggested to reduce incontinence has been these things, that the sweeping motions or the enucleation is better done anterior to posterior and from proximal to distal thing, so that the traction at the sphincter level is relatively reduced. So once the entire enucleation is done all across, we will be left with two options. Either leave it in situ and resect it out. So for someone who is just about starting and trying to venture into enucleation and not yet sure whether to invest in a morcellator, this is an ideal option that you can have. Dissect it all around, enucleate it all around, and then resect in the fossa. That would be a avascular adenoma, and the resection will not take too large a time. So this is one of the times that the final segment at the 12 o'clock apical mucosa would be other end, and you have to be more cautious as to you leave adequate length of the apical mucosa before you divide it totally. So this ability to resect in situ is not something which is very particular or very isolated to only bipolar enucleation. The same thing you can do even with laser enucleation also. You start off doing enucleation, do as much as you can, and whenever you feel that you have done a complete bacterium, we can go ahead and invest in a morcellation. The moment a morcellator is added, it becomes a very significant and easyful thing to your procedure. So now the entire adenoma is enucleated all around, and in this thing we usually tend to resect it off in situ. So that this modality is promoted as extremely cost-effective modality for scenarios where there are cost constraints. So any unit which would be doing a bipolar TURP can, with the change of a loop, take up bipolar enucleation and also, and the learning curve can be easily bridged. So these are the final look. I don't think so there is any difference in the final appearance of bipolar enucleation versus laser enucleation. And if there are any nodules which are left behind, it can be easily resected or vaporized at the end of it.
Okay. Is it done?
Yes, sir. Thank you, sir. Thank you for the patient listening, sir. Any queries from your side?
Yeah, we will take questions. So my first question is,
sir,
honestly, number of bottles, saline or saline bottles, same gland for you, bipolar enucleation, when you do, I am thinking that it will be nearly half at the end of morcellation also. Half that of the holmium laser enucleation. Is it correct or I am wrong? Number of bottles, because in India, some schemes will be there, insurance will not give money. Pharmacy is an important part of the package. Patient has to be informed what is the amount of the medicines used, like the number of normal. I hope you understand point.
Yes, sir, I get your point.
Used. Yeah.
So the crucial thing here is okay.
Yeah, I'm audible.
Yes, sir. The most important thing is two things, sir. One is the duration of procedure, how long it has been taken, because eventually the amount of irrigation that we use is directly proportional to the amount of time
Duration.
that you take for the surgery. Second one is the vision, sir. If the vision is not clear
No,
enough,
on an average, 80 grams gland, you are only doing. One day you choose yourself. Another day you will have some idea, not 10 years you have done.
there
Where
could
you
be I
where you
wouldn't
will have to use more bottles.
No, sir, I wouldn't say that if I use whole lab, the amount of irrigation would be dramatically 50% less, sir. There might be slight variation, but yes, not to that extent, sir. That to the extent that it becomes a major concerning factor for us to pick up whether we go ahead for a
There is
bipolar
no
or
major difference when you do it.
no,
You don't
not
consider that as the factor.
that as a significant factor. No, sir.
Okay. Number two, incontinence, whether it is transient 1 day or 2 days also. I am not asking statistics. Your experience only. This is purely your experience. When you remove the catheter, I have done few cases of enucleation bipolar. I have the mission. I have the loop. I have taken 12 degrees. I have given up very early phases before the TFL has come in 2018. So I started using it. Slightly better learning curve. I am enjoying that. Though at URP, I like more for less than 80 grams, 90 grams. Above 100, I prefer the laser enucleation to flap now. Now,
Yes, sir.
incontinence has never happened with TURP, very less often with two-flap, and little more often with the bipolar enucleation. All will settle after 12 days maximum.
Yes.
What is your opinion?
I totally agree, sir. TURP, the one thing is how big a gland that we handle usually is less. So what we have seen, the variations of incontinence with regards to enucleation, one of the most important thing is for the variation in the statistics is the gland size. So in literature, we have seen when you look into someone's study which shows that it is just 3% or 4% incontinence versus someone who is having coating 15% or 25%. We
Yeah.
also have to look what is the gland size they are tackling. So if we do enucleation for 50 cc, 60 cc gland, you will not get that 1 or 2% in incontinence also. So because yes, the adenoma itself is not distorting the sphincter. But vis-a-vis if it is a 100 gram
Large
gland,
gland, irrespective of technique, will have slightly more incontinence.
slight
In
incontinence, but
anatomical
yes,
endoscopic
TURP would be
enucleation.
still, TURP would be even relatively less as compared to enucleation.
Yeah.
One,
TURP is totally different. Bleeding will be
totally
more.
different.
That's totally different. You may not remove all the gland. That is a
That could be
different
one thing. And
comparison is
the
only
amount
between
of
these two.
rotational impact and the short of what I can say a neuropraxia or a stunning impact on the pressure impact on the sphincter might be slightly less with the TURP, wherein there is no shearing motion, only rotatory motion. Could be one thing. But yes, whenever you are using the mechanical force larger, especially in bipolar enucleation, the chances of incontinence definitely will be slightly higher as compared to laser. Your observations are spot on, sir.
Now, fourth question. In laser enucleation, after the half gland is enucleated, when you are doing between 4 o'clock and 8 o'clock position, we keep the laser fiber at 12 o'clock position. And whereas in the initial part, we keep at the 6 o'clock position. So that perforation of the capsule will not happen. By rotating the working element. Now, in enucleation, it is not possible. It's a fixed. So, when you come into the middle part of the lobe, very large gland when there is no space, good that you are making a trough in the beginning and anterior and posterior, that will safeguard. Even then, lateral part at the mid zone, large gland, when you are doing rotatory movement, what are the tips you can avoid, give for avoiding the perforation into the capsule, which is at the 4 and 8 o'clock?
Sir, first and foremost thing, the notion that by rotating upside down the laser element, we will reduce the chances of perforation. I fail to understand just by having laser coming at different direction, it makes us more easier. That cannot be the reason for perforations being less. So
Yeah,
there are many
but
experts.
what the logic
Yes,
seniors explain is,
The angulation at which it comes is different, and the perforation.
The angle comes at low, and always you try to go low only. Whereas if you keep it up, it will touch the gland, and
Yes, sir.
slightly 1 mm of gland layer you leave. And in fact,
Yes, sir. Yeah, that is yes, sir.
TFL, it looks,
The focus should have been, as has been put across by another author. If you are stretching the gland, there are strands in between adenoma and the capsule. You have three areas where you can fire towards the slightly.
Yeah, gland. Hello? Taif?
No.
Yeah. Hello? Yes. Yes. The voice breakage has come. Unmute the cell phone. Yes.
I'm audible now, sir? Yeah.
Yes, yes. So if you are 3 layers, one towards the gland, one perfectly capsule, one perforation.
So if you are in the zone where there is a lot of peripheral zone still there you have an element, say like the floor between the 4 and 8. Even if you go slightly towards the capsule, you have got a thickened peripheral zone there, and you will not perforate it. There it is fairly okay. The minute you come more anteriorly on the lateral aspect, it gets compressed. That is the area, irrespective of whether you rotate or you don't rotate, be towards the adenoma. That will safeguard you. In bipolar enucleation, what you are supposed to do is you have to rotate. It is slightly more cumbersome. Your your abduction at your joints would be a lot more higher, and you have to make sure that the probe reaches in that direction so that you come across. Eventually, if you want, you can rotate it all around and do it. But yes, the moment you rotate it and get it like a laser fiber, you tend to rely more on your mechanical force. So yes, we can do the same maneuvers with bipolar, but not as easy or as comfortable as lasers.
My fifth question. In case if the patient cannot do good extended lithotomy, which one is more easy, laser or bipolar?
Almost the same, sir. Almost the same. But again, I think you have to improvise.
I mean to ask, your movements are coarse in which condition in either of these two? Where you move a little coarsely. Some people use only like this.
Yes.
People like
so if the lithotomy is not going, extending, abducting adequately, you have to core through and go more from distal, make a core and just keep pushing. You can't come this way and obliquely. So that is what is needed in bipolar enucleation. So yes, that could be a limitation that you might be able to do. You might not be able to do the same fine coring through apical incision and dissecting all around. So if you can negate your movement of your arm and the scope together, you might be able to still do. But yes, it will. These are one of the technical difficulties in enucleation if the abduction is not adequate enough.
My seventh question: if you are experienced in both, like you, if I give condition, which condition is not at all good for bipolar enucleation, and which condition is not favorable for laser enucleation? In your mind, when you see that gland, oh, it's not good. I mean, small gland, fibrous gland, very large gland, vascular gland, submucosal vessels, median lobe, large or irregular protruding gland. What is in your mind which says I don't want to do bipolar enucleation?
Sir, one thing where bipolar would be really difficult is any fibrous gland, say classically less than 50-60. We keep hearing that HOLEP is being done for 25-30 grams gland also, laser enucleation and all. Technically, yes, you can do, but that is exactly
You feel TURP is best in such glands, TURP or IP?
Obviously, sir.
Obviously.
Yes. Till 50 cc, 60 cc, I still feel TURP is the best.
And in fact, you should recommend as experienced person, you are saying that TURP, do it and get out fast, easy, and no complications.
Obviously, sir. Obviously,
Obviously.
the efficiency and the cost effectiveness will be much higher with
Much
TURP
higher.
for a 60-70 grams rather than trying to struggle and take much longer time with your enucleation and morcellation, if at all cost effectiveness is the main. But theoretically also till 60-70, it's almost the same. There's nothing advantageous with that. And the deliverables are also the same. So in fact, the youngsters tends to get lost here. And the focus is learning enucleation and holmium laser enucleation or thulium fiber enucleation as the solution rather than
It's an option.
focus has to be that mastering TURP is the crux and then comes enucleation. But yes, coming to your question, smaller fibrous gland, bipolar enucleation, where you tend to use more mechanical energy, is a nightmare. Just like for open prostatectomy, the dictum was more than 75-80 grams only. You
Because
try to do
you cannot put
for
your
a small
finger and
gland.
rotate because there is no pseudo capsule.
Exactly, sir. This is the same thing. Instead of finger coming from bladder, now the probe is coming from transurethral. And we do one such case, we'll remember it for our life. How we struggle prayers for a small gland is the same thing. Bipolar for a small gland, and you'll remember for rest of your life. For HOLEP, the one thing that would make a really difficult thing is sort of an unplanned thing. A person who is a sort of a 100+ gland and nicely congested thing, who is on antiplatelets, and he lands to you with hematuria, and now there is sort of a, you do a clot evacuation, and now you are in mix of a thing that you are being pressed to go ahead with it, because now theoretically you say that antiplatelets you can do, yes, theoretically you can do, but this kind of a underprepared patient and a congested gland, HOLEP will have a tough time, because during the procedure the vision and hemostasis is relatively inferior compared to thulium fiber or a bipolar.
Now, 8th question. I have seen when you incise with laser on either side of the large median lobe, anteriorly the gland and circumferentially at the distal part beyond the veru, I feel the incision with the monopolar hook is so precise, so fast you can go to the capsule. The way you are doing TURP of the chips bipolar in the initial, I am now with thulium fiber enucleation, I give a nice incision first. Within 5 minutes, both the sides, I give incision anteriorly. In fact, I give incision circumferentially also, so that half centimeter depth it will cut, so that the mucosa will need not be torn. Then I will change to the two flap. I'm really finding it easy. Then from beginning doing slowly, it will take a lot of time. But
Yes,
when
sir.
I put this in pure urology, enucleation laser specialist said, no, Chandramohan, for laser only we will take less time to incise. I cannot believe it. The laser will take less time.
No, sir. For the initial incisions or for the hemostasis just before morcellation, shifting to bipolar energy is anytime more easier, faster, and convenient.
Most
So it is
easier.
sort of, yes, sir. It is sort of being open with your approach. There is nothing harm that you combine the best of two modalities. Your observations are very true, sir.
Yeah, in fact, monopolar hook I use, bipolar also I use. Now coming to the last few questions, last two questions. In case, have you ever seen the trigonal perforation with bipolar enucleation is less common technically?
No, rather by subtrigonation might be more common with the bipolar enucleation, especially eventually what are the reasons for subtrigonation? One is wrong direction of your dissection, and along with that, if you are relying more on mechanically pushing, then that is 1 + 1 11 kind of effect. One is your angle is wrong, and then you are pushing more, so your chances of subtrigonation might be much higher with bipolar enucleation if you are not cautious enough.
Okay, so laser causes laser is more defined, precise.
Yes, you are at least not pushing yourself.
And change also.
Yes, you have a chance of correcting yourself the minute you feel that you are going deeper. And yes, eventually the most important reason is what is your direction of dissection.
Yeah, last question. Don't mind. It's a
No, sir.
audience say. What is the
sure.
first complication you have come across when nobody was around and you are doing alone, nobody initial phases. Now you are experienced, no doubt. You don't do that much blunder. Initial phases in bipolar and homium, in either of these two, what is the complication which you remember that it is a bad day?
See, one of the most difficult things that during the initial thing is you have started up. The initial time you pick up a very large gland, and it is taking much longer than you expect. And at one point of time, you feel you are lost. So it might not sound a very scary situation, but those are the situations which tends to depress you that whether I'm doing the correct thing, whether I'm on track. So I would say that this is more common what we encounter. Picking up large glands, getting lost in between in your learning curves and getting depressed and leaving it off. So this is one which almost everyone encounters.
Great
Being more
answer.
scared, scary situations like bladder perforations, it looks scary, but you have got a defined solution. At the most, what you have to do is a cystotomy and bladder repair. That is the maximum that you can do. It is not a scary thing. It is not a depressing thing. That is a technical error which is there. Being lost, being not progressing, and that hampering your motivation is something that I would suggest should not deter you. And this invariably each one of us goes through.
Okay. So I also agree. It's a good answer. It's not a complication. The neck strain, eye strain, not able to progress, moving here and there, losing some time. We think that URP can do the job and switching over it, and later on getting not interest. I think
It's exactly
continuously
the same
doing
thing like our
enucleation.
laparoscopy learning curve. It's just like a laparoscopy
Yeah,
learning
yeah.
curve. The simple
If you
thing
feel
what
that
you finish in half an hour,
your
you
hands
open.
are getting strained, they give up. Lot of people will give up. Lot
Yes,
of people will give up. At least laparoscopy cases sometimes will be less, but prostate cases will come. If you give up, you can never learn. I think after doing 100 cases, you can enjoy the ride. I think so, 50
yes,
to 100.
definitely,
You
sir.
can
You will
enjoy the
start
ride
enjoying
of,
after the 50 cases, definitely. Yes, sir.
after the 50 cases, you start enjoying. So that is good. Thank you, Taif, for nice presentation. Good. Thank you very much.
Thank you so